I'm sure you realize that AKI is a syndrome rather than a disease, and it's very unlikely, and I think it's illogical to believe that the pathophysiology of acute kidney injury will be similar across all the different causes of AKI, and it's illogical to believe that AKI associated with sepsis is similar in pathophysiology to AKI associated with cardiac surgery, to nephrotoxic drugs, or dehydration, or hypotension after major surgery, or diarrhea, or any of the various situations that in the clinical state are associated with acute kidney injury. So each condition will have different pathophysiological mechanisms at work, but whatever the events are, there are really serious obstacles in our ability to understand them because we don't have the means to investigate the kidney easily in a dynamic way. We cannot biopsy the kidney repeatedly, or indeed we cannot biopsy the kidney even once because it is not justifiable ethically and therapeutically. We cannot monitor renal blood flow on a global level every minute the way we monitor cardiac output or blood pressure or stroke volume or other variables that pertain to the macrodynamics. We cannot definitely understand local blood flow within the kidney in human beings. We could not assess minor changes in function that might alert us to major changes in function that will flow, and the information that we can obtain from urinary flow, biochemistry, or the microscopy of the urine is very limited. And so we have serious difficulties in our understanding. Nonetheless, when you try to understand what is the epidemiology of acute kidney injury, at least in my world, where acute kidney injury is most severe, that of intensive care, there are several epidemiologic studies. This is from Eric Hoster, published in Intensive Care Medicine, and they typically show that sepsis is a major driver or a major associated factor. And then there is a whole potpourri of different diagnoses that are associated with acute kidney injury, not necessarily causative of. And then there are judgments by clinicians, for example, that the patient has acute kidney injury due to hypovolemia, and as an intensivist, I always have a tremendous difficulty with that. Whatever the hell is hypovolemia, given that there's no volemia meter available to Homo sapiens. Other large studies published in JAMA by ourselves, again, come up with similar findings. So I think it's fair to say that sepsis and major surgery are the two leading causes, and then there are all sorts of other factors that potentially can lead to acute kidney injury. In the hospital, there is not quite as much literature, at least not as focused, not so prospective, but mostly retrospective based on medical records. And again, when you ask clinicians what the causes of acute kidney injury in this population might be, then you have these wonderful delusional frameworks of reference, such as decreased renal perfusion, which of course can never be verified or falsified. And so it makes it very difficult to just understand what's going on with the kidney. It is fair to say, however, that when you move out of the ICU, medications appear to be, in the perception of clinicians, to be more important, and contrast media perhaps more important, whether again they themselves alone participate or whether they're part of a multifactorial series of events of which the medications are only a component remains again open to question. And when you look at the mechanisms by which people believe that there is decreased renal perfusion in hospital patients who develop AKI, there is this concept that there is volume contraction. That's very difficult because, of course, as I said before, you can't measure volume, but at least we can measure blood pressure, and I think it's fair to say that hypotension features pretty prominently as a potential cause of renal or contributor factor of acute kidney injury in the hospital. Most of the time, there is a complex series of factors at play. And let me just dwell on the medications and the concepts of decreased perfusion and the concept of decreased blood flow. Let me dwell on radiocontrast because it's relatively easy to study its effect on renal blood flow, and we've done that. And you go into the cath lab and you look at what cardiologists do, and you go to the sheep lab, and you repeat exactly what they do with multiple boluses of radio contrast into the arterial tree over a period of time, which is the equivalent of the period of time required to perform an angiogram or an angioplasty or a stent. And then you can study whether there is indeed hypoperfusion with radio contrast. And when you actually look at it, and you're in a position to measure all hemodynamics, but also you have a renal artery flow probe and you're able to measure renal blood flow, you see that the administration of radio contrast is not at all associated with decreased perfusion, but in fact it is associated with an increase in renal blood flow for quite a significant period of time. You can see there for 8 hours of observation. So the conceptual framework of the hypoperfusion is causative, at least in this setting, is clearly problematic. When you look at another area which is really important, cardiac surgery, which is so frequently associated with acute kidney injury, and you try to unravel what the literature shows you in terms of potential mechanisms that are involved in the pathophysiology of acute kidney injury, you come up with a whole lot of factors, from hemodynamic factors to biological factors to activation of inflammation to preoperative risk factors, and you end up with a cartoon like this one, which is wholly uninformative. It doesn't tell you anything that's particularly useful clinically. You might as well have a 5-year-old draw a cartoon and say bad stuff happens. And so, again, this is not able to take us further in terms of therapeutic interventions. And if you want to be a little bit more sophisticated, you can look at these factors and how they potentially play over time and how each one of them may be amenable to intervention at different moments in the course of the patient's illness. But again, we do not have interventional studies that back this up as being meaningful. And you have all of these complex, transformative, and illustrative kind of diagrams that try to convey the complexity of what it is you're looking at, but it doesn't really help you. And if you go to sepsis, the problems are even bigger, and we've recently reviewed that. And again, you look at a summary cartoon like this one, where there are a variety of factors involved. There are injuries to the glycocalyx, there is edema, there is redistribution of flow away from the medulla to the cortex, there is injury to the organ with the administration of potentially of fluids that are nephrotoxic. There is the potential of edema of the kidney, which is a capsulated organ which might reduce renal perfusion. Sepsis itself, of course, is a profoundly inflammatory state, and all of the inflammatory components of sepsis may be toxic to the tubules and participate in generating tubular cell injury. And so you have an extraordinary complexity of activities that can logically and based on information be believed to participate in the pathophysiology of septic acute kidney injury, but their complexity is enormous, their interactions are not understood, the number of factors is gigantic, and the therapeutic implications are really difficult to understand. And so our ability, therefore, to prevent sepsis-induced acute kidney injury, whatever its pathophysiology might be, is significantly impeded by our lack of understanding. However, more recently, Alex Zarbok, who's here in the audience, attempted to show that there might be some interventions that can be applied to a unique population of cardiac surgery patients that have early markers of renal injury that might promise some results. And this is a randomized controlled trial within a single institution of patients with acute kidney injury that have biomarkers that reveal them to be at high risk. And you can see that if you take these patients and you randomize them to have standard therapy, or you randomize them to have the intervention, which is the application of the KDIGO consensus guidelines for the prevention of acute kidney injury in this setting, you see that you can alter a variety of interventions. For example, you will be seeking to increase cardiac output more frequently, and you will be able to deliver perhaps a higher blood pressure. So you have the ability to manipulate the macro dynamics. And of course, two important therapies that might come from that, if you apply the KDIGO criteria, would be stricter glycemic control and avoidance of drugs such as ACE inhibitors and angiotensin receptor blockers that might aggravate kidney injury in this setting. And if you do that, then you have a significant reduction in the incidence of acute kidney injury associated with cardiac surgery. So this doesn't tell us what of these actions in specific terms was responsible, whether it was increasing cardiac output, avoiding the drugs, increasing the blood pressure, or any combinations of the above. But it is useful because it provides us with a framework to understand that there are several interventions that we can manipulate and logically improve in order to avoid aggravation of acute kidney injury. So it's really worth some reflection. The traditional approach, in the absence of any understanding of the pathophysiology of AKI, is to give fluids. That's very common, it's widespread, it's almost like a religion, and you see it everywhere in the wards, in the operating theaters, or in the ICU. And we have very limited information of what is really a universal intervention and about its effects on kidney function. The only RCT that was done, randomized controlled trials of fluid therapy in the ICU population, that is multi-center, high-level, kind of phase 4 randomized trial, was in the ARDS population by the ARDS network, and didn't necessarily focus on the kidney. However, when you look at patients that were at risk and you look at the management of those patients from the renal point of view, you can demonstrate, of course, as the patients randomized to a liberal fluid management received a lot more fluid over a period of time. And what you can find is that in the patients that were at risk of developing acute kidney injury, the incidence of acute kidney injury was decreased in the patients that were randomly allocated to a conservative fluid balance. And this is a unique population with ARDS, but it's a very sick population of mechanically ventilated patients, a very high risk with a lot of inflammation, and it certainly makes it very unlikely that the administration of fluids in critically ill patients is going to be beneficial to the course of acute kidney injury. So this is so much about fluids, no evidence of effectiveness, real fear that they're damaging, unnecessary, and might aggravate injury. What about blood pressure? You've seen a little bit of a signal in Zarbach's paper. Is there any other evidence that attention to blood pressure does matter in the pathophysiology of acute kidney injury? Well, we've looked at that in patients developing acute kidney injury in the hospital. And we published that some time ago. This is a single-center cohort of patients who developed different levels of acute kidney injury while in hospital. And we were able to look at their evolution, the movement from one rifle category to another in this population of patients. When you do a statistical assessment of the risk factors for these patients developing acute kidney injury, you find that changes in blood pressure from their pre-morbid level, not absolute blood pressure levels, but changes in blood pressure from their pre-morbid levels downwards is a very powerful predictor of whether people will develop acute kidney injury in the wards, suggesting that if you're going to worry about blood pressure, that's not quite enough. You have to target or think about targeting a blood pressure that is relevant to the patient in question. And that obviously goes to trying to understand epidemiologically what it is that hypotension is. And I think this is probably the most interesting paper from the point of view of surgical patients, because it looked at a massive population of patients from the Cleveland Clinic. And this is 33,000 people having surgery, and looking at the blood pressure just in the operating room and the probability of acute kidney injury developing. And you can see a real takeoff in the risk of patients developing acute kidney injury at a blood pressure about below 60, between 55 and 60. So this is only in the operating room. So even a short period of exposure to low blood pressure is associated with the development of acute kidney injury. And if you look at the duration of such epidemiologically defined hypotension, it shouldn't come to you as a surprise that both for the kidney and the myocardium, having persistent and extended hypotension is associated with increased risk. And you can see the specific and quite strong probability of acute kidney injury and myocardial injury occurring over time if you have a blood pressure below 55 millimeters of mercury. So this is associative data. It's not causative data, but given that we can easily manipulate blood pressure, it certainly makes one very concerned that we're not potentially paying enough attention to it. And this is also adjusting the blood pressure for the central venous pressure and looking at perfusion pressure for the kidney. So a recent paper, again, looking at patients in the intensive care unit. And you can see that if you have a mean perfusion pressure deficit, with the perfusion pressure being your mean arterial pressure minus the central venous pressure, you have a progressive increase in the risk of developing acute kidney injury. So this is all associative data, and obviously it has the clear limitations of not allowing us to draw any inferences about cause. These may just be markers of patient's illness that is associated both with hypotension and acute kidney injury. More interesting in relation to blood pressure is the randomized control trial conducted in sepsis by Pierre Affar, looking at those with sepsis that are treated to target a higher blood pressure between 80 and 85 versus those that are treated in a conventional way. This is a graph of the distribution of blood pressure in the ICU, and you can see the difference between the two cohorts. When you look at the overall kind of outcome of these patients, you see that there is no difference except for when you look at patients with chronic hypertension. In those patients, there is a 52% incidence of doubling the serum creatinine if you're allocated to a low blood pressure, and there is only a 40% or so incidence if you're allocated to a high blood pressure, suggesting that your blood pressure target, again, should be perhaps adjusted for the characteristics of the patient. Now let's see if I finally can show you some interesting stuff that we've, that we've recently used to try and investigate what might be happening to the renal circulation. This is a new technology of ultrasonography, which is called SMI, which stands for Superior Microvascular Imaging. This is the kidney of a sheep, which is in septic shock or noradrenaline infusion to maintain a reasonable blood pressure. And I'll try to show that again. It's very difficult to argue that the cortex of this animal is hypoperfused, and it's actually very much similar to normal levels of perfusion. Let me take you now to another animal. This is an animal that we just put on bypass, and the animal has a blood pressure of about 45 to 50 millimeters of mercury, or mean arterial pressure. Okay, this is cool. Now, the same animal now goes on noradrenaline or norepinephrine. So you can see the dramatic change in cortical perfusion at a microvascular level with ultrasonography when you compare, I'll just go back and show you, a hypotensive animal on cardiopulmonary bypass to a normotensive animal now with a mean of about 75 to 80 with norepinephrine support. So let me summarize that AKI is a diverse syndrome. Its pathophysiology is similarly very diverse. All explanations that we currently have are speculative and based on associations. Outside of the obvious things, their therapeutic implications are very unclear. However, there is a great deal of doubt about the usefulness of fluid loading In contrast, there is reasonable evidence which is associative, reasonable evidence which is randomized, and reasonable physiological imaging evidence that defending the blood pressure is a potentially useful thing to do to protect the kidney, no matter what the pathophysiology is. And I think ignoring such recurrent observations is probably unwise. Thank you very much.